Welcome to our webinar, Medical Jargon Made Simple. Thank you so much for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the webinar today. As we get started, I'd like to recognize the generosity of our corporate sponsors, Amogen, Apellis, Tahoe Oncology, Alexion, and Merck, and the generous support of our patients, families, and caregivers for supporting the webinar today. I'd like to let you know a little bit about one of our opportunities for you and your family to be able to connect with others. We do host support groups each month. These support groups are virtual and they are led by patients and caregivers. These are opportunities for you to meet with others, share your experiences, and learn from each other. To find the support groups, they are on our website at aamds.org. And once you register for the group of your choice, you will receive a confirmation email. In that email, there'll be the logon information for that particular group. Now let's get started with the webinar. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or a comment, just open the Q&A text box window, type in your comment or question, and then just hit enter. We'll do our best to get to everyone's questions today. When asking questions, please be sure to submit your question all at the same time. And second, please do not share private health information in your question. Our speaker today cannot answer any specific questions related to your health care. We are pleased today that Jennifer Lauder is our expert today. She's originally from New York and moved to the Washington, D.C. area to attend George Washington University School of Medicine and Health Sciences, where she earned her PA degree. Her clinical focus is pediatric and adult patients with hematological disorders. She's a physician assistant in the National Heart, Lung, and Blood Institute at the National Institutes of Health, located in Bethesda, Maryland. It's my pleasure to welcome Jennifer today.
Thank you for that wonderful introduction, and thank you to the AAMDS International Foundation for inviting me to speak. I'm going to go ahead and share my slides. Okay, hopefully everyone can see that.
Looks great.
Great, thank you so much. So I'm here to speak about medical jargon, and as Lee mentioned, my name is Jennifer Lauder. I'm a physician assistant at the NIH at NHLBI, and I've been with the hematology department for about 9 years, working with both pediatric and adult patients with hematological disorders. I have nothing to disclose. All the information and opinions are my own and do not reflect the United States government. So let's get into medical terminology. So medicine has its own language. Before I went to PA school, before they even let me take graduate courses, they gave me a big textbook and they said, learn this medical terminology because it is a whole new language. And providers will use terms among ourselves, and we're so used to speaking in this language that sometimes we forget that it might be new to patients. So very briefly, I'm just going to give you kind of the short of it, which is it's always helpful to break it down if you don't understand it. So all of the medical terms can be broken down into 3 parts. So the prefix, the root, and the suffix. So the beginning, the middle, and the end of the word. Hold on one second. So at the beginning of a word term, you have a term that modifies the base word. So it can indicate size, speed, location. So looking at these examples, we're all familiar with hypertension. So hyper means above. So your pressure, the tension, is above normal, high. And then these are some other common ones. So macrocytic. Macro means large, and cytic is cells, so large cells. So you can kind of look at the word itself and break it down to have a better idea of what's going on. And then you have the primary meaning, cardio, neuro, things like that. It's usually, that's the easy part. And then at the end of the word, you might have something that indicates what the test is or the type of procedure. So again, these are common endings to medical words. Pericarditis. Cardio means heart. Peri means around. Itis means inflammation. So we have inflammation around the heart as an example. And then we have medical abbreviations and acronyms. So these are shorthand versions of common healthcare terms. And this is something that we probably use the most and forget that we use as medical providers. So we will say AA and just mean aplastic anemia, or MDS and say it's myelodysplastic syndrome. But we use these shorthand versions so frequently that, we forget that when I say I ordered a CBC, a patient may not know that means complete blood count and what that entails. So let's look at blood basics. So I'm going to go over terms generally. These are all common terms that you'll see in hematological disorders. We'll go over terms and tests and diagnostics. Okay, so at the very basic level, heme is a term for blood. So if you take heme, you have hematology. Ology is study of, hematology is a study of blood. Hematologist is a doctor who specializes in blood. And then oncology, because oftentimes hematology and oncology go hand in hand. Onc means tumor. We have oncology is the study of tumors or cancer. An oncologist is a doctor who specializes in cancer. All right, so let's go specifically now into bone marrow failure. So AA is an abbreviation for aplastic anemia. And there are terms that go into disease severity. So MAA is moderate, SA is severe aplastic anemia, VSAA, very severe aplastic anemia. But really, aplastic anemia is more than just anemia. It's a bit of a misnomer. Aplastic means that the bone marrow is empty. So it's a failure of the bone marrow to produce cells. So and I'll go into detail about looking at bone marrow reports and what that may mean, but when we break down the words again, we have hypoplastic or hypoplasia, and in reference to the bone marrow, that means less than, hypo. Less cells are being produced than normal. So COMITA criteria is something you'll hear a lot in aplastic anemia classification. So classification is a way for us to kind of categorize how the severity of the disease. So if you are classified as having severe aplastic anemia, SAA, you have a marrow cellularity less than 25%, plus at least 2 of the following, the peripheral blood findings. And I'm going to go through what these different blood types mean. So you have neutrophils, platelets, and reticulocytes, and they're all really low. Now, to get to very severe, your neutrophils have to be less than 200. Here, this is 500. And then moderate is if you do not meet this criteria. So your cell counts are still low, but you don't meet the criteria that's listed here. MDS. So MDS stands for myelodysplastic syndrome. Dysplastic means abnormal. So myelodysplasia is abnormal cells. So blood cells that are poorly formed or don't work properly. And when we look at MDS, we're going to look at hyperplasia and hyperplastic bone marrow. So there's hyper means more cells than normal. And then going to PNH, this is a mouthful, but PNH stands for paroxysmal nocturnal hemoglobinuria. And it's also a misnomer because it was initially named after just one symptom, which is dark urine. But those of you that are familiar with PNH will know that there's a lot of other symptoms that go into PNH, but the name itself just comes from the dark urine. Paroxysmal means sudden, nocturnal means night, and hemoglobinuria refers to the dark P. So it's actually hemoglobin in the urine. Red blood cells in the urine is something different. That's hematuria. So when we ask our PNH patients if they have dark P, it's actually the hemoglobin in the urine we're asking about. So it's a protein and it'll look tan or brown versus hematuria, which is bright red blood in the urine. Okay, so normal blood cells. There are really three categories of cells we are most concerned about. So we have the red cells. Those are the cells that carry oxygen. When you don't have enough red cells, your hemoglobin is low and it's called anemia. White cells are also called leukocytes. Leuko is white, cytes are cells. So leukocytes are white cells and they help fight infection. You have many different kinds of white cells. The one we tend to focus the most on are neutrophils. And when neutrophils are low, you have neutropenia. Those are the cells that fight infection. And then lastly, you have platelets. So they help to form clots and stop bleeding. A thrombocyte is another name for platelets. So thrombocytopenia means you have low platelets. Okay, your peripheral blood counts. So as I mentioned before, CBC stands for complete blood count. And platelets are low, you have thrombocytopenia. We can transfuse platelets if they become too low. White blood cell, ANC is what we focus on. So we'll talk a lot about ANC when we're talking about white blood cell count. But as I mentioned, there are a lot of different cells that comprise a differential. So that's when we break down all the types of cells in a differential. And part of the differential is going to be that ANC, and that's the absolute neutrophil count. When the ANC is low, it's neutropenia. Hemoglobin, red blood cells, anemia. All right. So let's talk about the actual bone marrow. What is bone marrow? So if you're looking at a bone, it's hard on the outside, but it's actually pretty spongy with blood on the inside. And it's an essential part of your body where blood cells are produced. The production of blood cells is called hematopoiesis. So that's the production of blood cells. And we have to look in the marrow itself to see if they're being produced. And the test that we do for that is the bone marrow aspiration and biopsy. So we have to look at the bone marrow. How do we do that? So the one way is to take the fluid and the cells through a needle, and that's the aspiration part. So we just take the fluid and the cells. It looks like blood. And then if we want to look at the biopsy part of the bone marrow, we remove a piece of the bone marrow. So biopsy is removal. So the term biopsy can be used in a lot of other things. You can have a skin biopsy, so removal of a piece of skin, lung biopsy, removal of a piece of lung. In this case, bone marrow biopsy, removal of a piece of bone marrow. Okay, this is a very complicated chart. Don't let it scare you, but I do want to show you that at the very beginning in your bone marrow, you have stem cells. This is a stem cell. And then when you have bone marrow failure, this whole chain of development is stopped. So this is a whole, so if you look here, we're going to start with what we already talked about, platelets, thrombopoiesis. Poiesis means the production of, and when you have platelets going back, and this is all stopped, you're not getting the platelets, the megakaryocytes is what is in the bone marrow. So you might hear no megakaryocytes. So in the bone marrow, you don't have production of the megakaryocyte that would eventually become platelets. Again, you have the stem cell, but it's not developing, it's not being produced. So these are the red blood cells here, erythropoiesis, development of red blood cells. And you'll see these erythroblasts and reticulocytes. And this all happens in the bone marrow normally, but it doesn't happen here in bone marrow failure. And then white blood cells, there's lots of different types. Granulopoiesis, development of white blood cells. Granulocytes are neutrophils here, and this whole part of the chain is stopped. Okay. So when you look at your bone marrow biopsy results, you have to ask how we look at the results. We ask ourselves some questions. And this is for any bone marrow failure syndrome, MDS or aplastic anemia. So how many cells are there? Too few, then it's aplastic or hypocellular. Too many, hypercellular. Average number of cells, normal cellular. And we compare it to what the average number of cells are for someone else of that age. Because as you age, the cellularity just naturally decreases in your bone marrow. You just do not make as many cells. So it's all adjusted for age. And how do the cells look? Do they look normal? Morphology is form and structure. So morphology is how the cells look. And if it's dysplastic, that means it's abnormal. And there's many ways that the cells can look abnormal. This is all evaluated by a pathologist who is a specialist. A hematopathologist is a pathologist that specializes in looking at tissue related to hematology. And they look at the bone marrow very closely. They have lots of different stains that can evaluate these types of things, such as fibrosis. And then, we're asking, is there fibrosis in the bone marrow? So that's the increased number or thickness of the fibers that are around the marrow, and that's graded on a scale. So these are all things you might see in the report. Another thing is ring sideroblasts. So sideroblasts are early red blood cells with rings of iron around the center. These are abnormal. Usually there are no sideroblasts in the bone marrow. So if you're seeing them, and there's a lot of them, that's abnormal. And speaking of blasts, blasts are abnormal, immature white blood cells. You may have normal blasts in the bone marrow. You should not have blasts in the peripheral blood because they should mature into healthy cells before they leave the marrow. If you have too many blasts in the marrow, so too many immature cells and they fail to mature, or they're crowding out the production of normal cells, then you'll get to a diagnosis of MDS or AML, which is an acute myeloid leukemia. All right, so let's go into cytogenetics, another term you're going to see a lot. So every time you have a bone marrow biopsy, we like to try to send out cytogenetics. It's a type of genetic testing. Cyto means cell. So we're looking at the cell and we're examining the chromosomes for any changes or abnormalities. So normally we'll have 23 pairs or 46 total chromosomes. And of that, one pair is going to be your sex chromosome. So you'll have either XX or XY. XX is for female, XY is for male. And then, so it'll be reported that way. You'll see that. But the chromosomes can be broken, they can be missing. If they're missing, it's usually called a deletion. They can be rearranged. So you have this pair and they can swap places, or you can even have extra. So instead of having a pair, you might have three. Some of these don't really matter, and some of them matter a lot. And without going into the detail of all of this, we want to check and just see what your chromosomes look like, because some of them can lead to a diagnosis of MDS. Okay, and then we run the cytogenetic testing from the marrow. Another test we often use is called FISH. So FISH, it's kind of a funny name, but it stands for fluorescence in situ hybridization. And it's really a name of how the test is run. I'm not going to go into that, but what the test looks for is gene changes in the cell. And it uses a probe marked in dye, the fluorescence. We kind of like fluorescence that lights up, and we can see where the chromosomal differences are. And the FISH testing is more sensitive than some other tests. So you may find the same abnormalities as the cytogenetic testing, but it's more specific. It can detect others that are too small, because what they do is they run each cell through one at a time. So you can see it more clearly. So we use FISH to detect things like monosomy 7, because they'll look directly at that one chromosome. All right, let's get into more genetic testing. So for genetic testing, you'll hear a lot about whether genes are inherited or acquired. So genes are your DNA, and they can be passed down from your parents. You get genes from both parents. Or you can, after the embryo is developed, your genetics can change at some point as you mature. If it's inherited, that means the mutation, which means it comes from your parent. This is also called germline. If it's acquired, it happens randomly. In acquired aplastic anemia, it's usually immune mediated through your immune system. That's your immune system is how you respond to foreign bodies. And if it's idiopathic, we don't know why. So idiopathic, it's not explained. We don't have a good reason. Inherited, we know what genes may cause it, because those genes probably came from your parents. Sometimes they don't, in which case it's called de novo. Just comes new. Novo is new. And let's go to the next one. So the way we look at, oops, I don't know how to go back. There we go. The way we look at that is called NGS testing, next generation sequencing. So we will do a bone marrow failure panel. And this gene sequencing, it looks at variants and mutations. So again, we're looking at your genetics. If it's responsible for causing the disease, it's called pathogenic, disease causing. VUS, this is something that comes up a lot. So we're still studying the genome and trying to figure out what genes cause different diseases. So a variant of unknown significance means it's, we found it. It's not something we usually find, but we don't know the importance. Benign means harmless. So benign, there's nothing that we know of about this gene that would affect the person to cause the disease itself. And NGS testing is used to diagnose the most common genetic causes of bone marrow failure. So we do know some of the genes and some of the inherited reasons why you might have bone marrow failure. There's several, but I'm just gonna list these two here. DKC, dyskeratosis congenita, is a telomere disorder. And another test that is often run is telomere length testing. So the telomere is a protective cap at the end of the chromosome. And the shorter the telomere is, the more exposed the chromosome is, and the more vulnerable it is to breakage. And when the chromosome breaks, it can cause disease. So we look at the length of the telomeres. In dyskeratosis congenita, they're very, very short. Other things can cause very short telomeres, like chemotherapy, because you're breaking down that protective cap. FA is Fanconi anemia. So there are genes that are identified in Fanconi anemia that are screened during this NGS testing. Another test I just wanted to mention here is this DEB, Fanconi anemia test. It's specific. So if you don't have access to the NGS full panel, they will do a DEB test. It stands for diepoxybutane, which is how the test is run. I guess I'm not going to get into the details of that, but you might see Fanconi DEB testing, and that's pretty specific to Fanconi anemia. It's a breakage test, and it'll let us know whether you have Fanconi or not without the genetic testing. Okay, so going back to mutations, acquired mutations are also known as somatic mutations. Somatic is relating to the body. So when you have acquired mutations or variants, they are prognostic risk factors for MDS. If you have them, a lot of people will have some sort of variant, but it's how frequent they are, what percentage of the cells they occur in. So if it's very low, it's usually not significant. And this VAF is variant allele frequency. So it's that specific thing that's different and how frequently it happens. And it's in a percentage. And it's a percentage of how it's detected in the specimen. And it correlates with disease burden. And there are certain somatic variants that are associated with disease that we are aware of, such as PIG-A is a mutation associated with PNH, and SF3B1 is a mutation associated with MDS. So when these variant allele frequencies become pretty high, it's a prognostic risk factor for these diseases. Okay, so let's go into IST, immunosuppressive therapy. That's what IST stands for. If something is autoimmune, it means the immune system fights its own healthy cells. So the body turns against itself. Immunosuppressive therapy aims to inhibit that activity in the immune system. So you want to stop the body from turning on itself. In aplastic anemia, the standard of care is triple therapy. So triple therapy is horse ATG, cyclosporin, and altromapag. So horse ATG and cyclosporin are both immunosuppressive drugs. Altromapag is a growth factor. So we'll go into that. But horse ATG, so or HATG, it's horse anti-thymocyte globulin. So back in the day, they used rabbit, and it's still used here and there, but mostly replaced with horse now. But they treat horses with this serum, and then they take this from the thymus, and then they use that to make this medication. So that's where you get the horse and rabbit part from it. It's how they cultivate these immune cells. And it fights the immune system cells so the body can regenerate healthy cells. So you're suppressing the immune system, the part of the body that's fighting itself, so that the good part can take over. And serum sickness is an immune response to the medication. So horse ATG, you're at risk for serum sickness because you're having this horse and medication derived from the horse into your body, and your body may respond to that with serum sickness. But we have medications to help with that, prevent it. Okay. So here we have some common terms just to speak about what state of the disease you're in. So this is more or less about post-treatment. So AE is an adverse effect. So if you're on immunosuppressive medication, you might have some side effects that are related to the medication. Adverse effects can be mild to severe, causing you to stop the medication, but you might hear the term AE, adverse effect. Refractory, if you have refractory aplastic anemia, that means you did not respond, so it didn't work. Response means the therapy worked, and you can have varying levels of response. So it can be partial, complete, or suboptimal. So partial means you've had some response, but maybe, and you're transfusion independent, you're doing fine. Complete means you've had a really good response, your counts may be close to normal. And suboptimal means you may still need transfusions every now and then, but you're not transfusion dependent all the time. Relapse. So you had the therapy, it worked, you had some type of response, but now your disease has come back to the point where you would need another line of therapy. That's what relapse is. Remission are reductions or disappearance of the disease. So, you can be in complete remission, which means we cannot find any traces of the disease. And then on the other end of that spectrum is progression. So the disease has changed into another disease. For example, aplastic anemia can progress to myelodysplasia. MDS can progress to AML. So these are different changes to different diseases. All right. So MDS classification is a hot topic. It is very complicated, but I do want to introduce it because there's a lot of different acronyms and a lot of different categorizations. So the two ways to classify MDS that are most used are the ICC and the WHO. ICC is the International Consensus Classification, and the HWO is the World Health Organization. And what these two classifications and systems aim to do is predict a person's risk of developing AML and their risk of overall survival, their prognosis. And what category they're in, it goes from very high risk to very low risk. But all of this will determine what type of treatment a person with MDS receives. And it's a score, and you can, it's scored on many things. Okay, so a little more on treatment. So we have, I mentioned before that eltrombopag is a growth factor. So what it is it helps promote platelet growth. So growth factors are medications that increase the amount of the cells that your body makes. For red cell growth factors, you have EPO and darbepoetin. These are all examples of red cell growth factors. So they're helping promote the production of red cells. And then you have the promotion of white cells with growth factor. So GCSF, which stands for granulocyte colony stimulating factor. So stimulating means you're pushing it to grow. And these are examples. This is another name for it: filgrastim, Neupogen, or Neulasta. Those are all examples of white cell growth factors. So you're trying to increase that white cell count, your neutrophils specifically. And then platelets. So thrombopoietin receptor agonists. These are all just names for medications that promote the growth of these cells. All right. PNH. So the common things you'll hear with PNH specifically is GPI anchor proteins. So GPI stands for a very long word. I'm not even going to say that one, but that's what GPI stands for, and it's how we measure the percentage of PNH within the cell. And it's measured by flow cytometry. So it looks at a very specific type of cell, and you have a population of cells that are affected by PNH. And specifically the red blood cells, the erythrocytes, those are the red blood cells, the red cells in the bone marrow. And they lose these proteins, these GPI anchored proteins. And it's a clonal population, so the PNH percentage will be variable. And it changes, it can increase or decrease over time. Intervention usually occurs when the PNH percentage is greater than 50%. When we look at your laboratory work, we're going to look at the LDH. LDH is part of a common chemistry panel. It's an enzyme. It stands for lactase dehydrogenase. It's usually elevated in PNH because what happens in PNH is you have hemolysis, you have the breakdown of red blood cells. And when the red cells break down, they release this enzyme. So if you're having the red cells breaking down, the enzyme goes up. And then DAT is a direct antiglobulin test. It's also called the Coombs test. And it's looking to see if your red blood cells are covered in antibodies. In PNH, this test is usually negative because it's not that type of autoimmune hemolysis. Okay, so I was mentioning this before. So in PNH, you have this breakdown of red blood cells, hemolysis. It's through the complement system, and you have intravascular hemolysis and extravascular hemolysis. So intravascular, so intra means inside, the vascular, the vessel. So breakdown of red cells are within the vessels. Extravascular hemolysis means extra is outside. So outside the vessel, breakdown of red cells outside the blood vessels, and this usually occurs in the liver or spleen. So the complement system, it's proteins in the immune system. It helps fight infections. The one we look at specifically is C5. There's a whole complement cascade. Again, very complicated. But this is the one that plays an important role in PNH, and the treatment involves inhibiting that complement. Okay, I'm just going back to infusions versus transfusions. So this is, these are terms that are really quite similar. So the only difference is really infusions refer to medication specifically, and transfusions refer to blood. Transfusion just means the transfer. So you're transferring blood from someone else to another. Infusions, you just take the medication and infuse them directly. But they both go through IVs, which is into the vein. And then MABs, this is a shorthand term for monoclonal antibodies. So these are proteins in the lab that are made to act like our body's own natural defenses, our antibodies. Antibodies are made by our immune system to recognize what's foreign. So if you're not making your own, we give them to you. And examples of this would be eculizumab, ravulizumab. So they all end in that MAB, all the medications that are monoclonal antibodies. Okay. Anticoagulation. So let's break down this word. Anti means stop. Coagulation is the process by which blood clots or sticks together. So if we want to do anticoagulation, we want to stop the blood from sticking together, also called a blood thinner. Some PNH complications. Thrombosis is a blood clot. Similarly is thromboembolism. So the difference is just that there was a circulating blood clot that gets stuck. And different types of thromboembolism or thrombosis is DVT, which is a deep vein thrombosis. So it's just telling me where that thrombosis is in the deep vein, usually of the leg. And PE is telling me where the embolism is in pulmonary. Pulmonary, pulm is lung. So PE is in the lung, DVT is in the vein, usually of the leg. And hemorrhage just means excessive bleeding. Okay, and this is the last section of my presentation. I just wanted to touch on bone marrow transplant because it is an option for bone marrow failure. Bone marrow transplant is also called a stem cell transplant because you're taking these immature cells that start at the very, very beginning of that chart that I showed you. And when they start at the top of that chart, then they develop into any of the other cells below it. So it's giving you new stem cells. And you can get those new stem cells from someone else, in which case it's called allogenic, donated cells, or you can get them from your own body, autologous. So most transplants, I would say, are probably allogenic in bone marrow failure. So you get donated cells from somebody else. If you were getting it from your own body, they would have to take the cells away and give it back to you after passing through a special machine, and that's called apheresis. Okay. A donor is someone who gives something to someone else. There are many types of bone marrow donors. The two that we often use shorthand for is haplo. So haplo means half. So you get your genetic material half from your mom, half from your dad. So a haplo donor is going to have half of the genetic material. So a haplo donor is usually a parent or a child, because you're giving half your genetic material also to your children. Get half from your parent, give half to your children. So haplo donors tend to be a parent or child. Also, siblings can be a haplo donor if they get different halves from the same parents. A MUD is a matched unrelated donor. So there's a donor registry, usually Be the Match. They collect all the information about people that are willing to donate around the world. And we can look in a registry to see if there's a donor that has the same genetic material, alleles, the same parts of the DNA that we're trying to match. And in that case, they're not related to you, but they might be even a better match than someone related to you. And that's a matched unrelated donor, a MUD. And just some common terms in bone marrow transplant, we have conditioning. So we're trying to suppress the immune system so the patient won't reject the new marrow. So, calm down your own system so that you're accepting something new and it doesn't attack it as foreign. And one way to do that is through chemotherapy. Cytotoxic, so cyto is cell, toxic, not good for you. So cytotoxic, you're killing the cells. And in chemotherapy, you kill off all the cells, good and bad. So depending on what kind of regimen you get, you might have reduced intensive chemotherapy. And then GVHD, graft versus host disease, is a complication of bone marrow transplant. So the donor cells attack the patient's body as foreign. So you're getting these cells, and part of when they're put in this new environment, they're not very happy. So it causes complications. And that's usually in other organs like skin, liver, gut. And engraftment, how well the graft, so the graft is the donor cells, engraftment, how well the donor cells are accepted by the recipient. All right, I think that's actually it. So my takeaway really is that there is so much that happens in medical terminology. Always ask questions. So, if you're not comfortable asking them directly, write them down, write down things you don't understand, bring them to your appointments. And, we are, as providers, we sometimes use shorthand or abbreviations all the time, and we forget that it may not be clear to the patient. So always ask questions. And on that, I will turn it back to Lee.
Great. Thank you so much. We have some great questions. Our first one is, can you explain the difference between what is a bone marrow biopsy versus a bone marrow aspiration? What's the difference?
That's a great question. So the difference is both. I should start by saying both usually happen at the same time during the procedure. So you take the needle into the bone and you'll take some blood first, and that's the aspiration. And that goes for testing to the pathologist so that we can see the cells. And then you keep going and you take a biopsy. So you're taking the blood first is the aspiration with the needle. And then you take the needle and you take a little part of the bone itself, of that middle squishy part, and that is the biopsy. But both of these things happen like you almost, right away. So you take the blood, then you take the bone. So it's one of this, it's usually the same procedure. I hope that helps.
Yes, thank you so much. This question is in regards to physicians. My oncologist says that the hematopathologist will review my slides. What's the difference between a pathologist and a hematopathologist?
Yep. Great question. So a pathologist is someone that is a doctor that looks at tissue. Very general. A hematopathologist is a type of doctor that looks at tissue, a type of pathologist, but specializes in blood. So they look at blood specifically and blood tissue like bone marrow. So that's what a hematopathologist is, but they are a type of pathologist. Other types of pathologists look at other types of tissue like a breast biopsy or a liver biopsy, but hematopathologist is specifically blood.
Thank you for that. Our next question is there a criteria for determining someone who is immune compromised? What is really meant by immune compromised?
I get this question so often, and it is an incredibly difficult question to answer because it is not straightforward. If you have a diagnosis of a malignancy like MDS, you're going to be automatically put in the immune compromised category. How severe you are immune compromised is weighted on lots of different scales. One being your neutrophil count. So neutrophils help fight infection. So being immune compromised means your immune system isn't working 100%. So if your neutrophils are very low, if you're neutropenic, you are immune compromised. If your lymphocytes are very low, so after therapy, we see this count called a CD4 count. That's another type of looking at your white blood cell counts. If you have a very low CD4 count, you are also very immune compromised. And what being immune compromised really means is that, your immune system isn't functioning properly, so you're at higher risk of getting infection. So it's not a straightforward answer because there's obviously a range of, you can have both your neutrophils low and your CD4 count low, among other things, or one or the other. So it's really a scale, and it's something I would encourage you to discuss directly with your doctor about what factors you have that put you at risk.
Thank you for that. Our next question is, what are the important factors from a CBC in regards to aplastic anemia?
Yep. So when I see a patient, I highlight a few things, and I'll tell you what they are. So the ones that are big are the hemoglobin. So that's red blood. So if your hemoglobin is really low, usually below 7 or 8, you would need a red blood cell transfusion. So I'm going to look at your hemoglobin. How low is it? And if it's very low, you'll start to feel symptoms. When I'm looking at a CBC, I'm looking at your platelets. How low are your platelets? If they're less than 10, you might need a platelet transfusion. Or if they're very low and you have symptoms like bleeding or petechiae, which are the little red dots on your skin, again, you might need to be transfused. So hemoglobin, platelets. On your CBC, there's going to be a lot of other parts of the cell, their size and volume, and those are not going to matter as much. So just focus on hemoglobin, platelets, and white blood cell count. So you have the total white blood cell count. Now, the white blood cells, there's many different types. So I'm going to wait for them to break that down, and that happens in the differential part of the CBC. So oftentimes the CBC will come back. We'll see your total white blood cell count, but I'm going to have to wait for the differential, which has, absolute lymphocytes, absolute eosinophils, absolute monocytes, but the most important one is going to be neutrophils, absolute neutrophil count. How low are your neutrophils? Because that will let me know at what your risk is for infection. So hemoglobin, platelets, absolute neutrophil count are the most important.
Thank you so much for that. What is the difference between being asymptomatic versus being in remission?
So they're referring to two different things. So when you're in remission, you will most likely be asymptomatic because it means you've responded and that you're not showing signs of the disease. So they're very similar, but asymptomatic means having no symptoms. Asymptomatic, a part is absence of. So, if you're in remission and you're doing well and there's no signs of the disease from a laboratory point of view, then you shouldn't really be symptomatic from the disease, right?
Thank you. Our next question is, what do you recommend as the best patient resource to correctly define medical acronyms?
Yeah, so honestly, I think that the AAMDS International Foundation has a really good glossary of terms that you can refer to. And then, I would keep it to hematology, specific medical websites. So, up to date, Medscape. I would look specifically for things pertaining to blood with the American Hematological Society. So, I just straight up Googling might get you in trouble, but just make sure you're checking your sources.
Thank you for that. Our next question is, can you please define what does it mean to be transfusion dependent?
Yes, I can. And thank you for that question. So we have patients that have low counts, but they're not low enough to need transfusions. Now, when you're transfusion dependent, means your body, your bone marrow is not working to the point where you're not producing any cells. So the only cells that you have are ones that we give you through transfusion. So the two types of transfusions we give patients are platelets and red blood. So a patient can be dependent for one and not the other. So if their platelets are very low, they'll need platelet transfusions, but they might be producing red blood, so they don't need red blood cell transfusion, but they would still be dependent for platelets. So they're still transfusion dependent for platelets. Our patients with MDS and PNH, they're more likely to need red blood. So they're anemic, they're not producing their red blood cells, or their red blood cells are breaking down so fast that they can't maintain a red blood cell count that keeps them feeling well. So they're feeling short of breath, they have headaches. In that case, they need red blood all the time, and then they're red blood cell transfusion dependent. So they need to get a platelet lasts about 3 days. So transfusion dependence for platelets means you need a transfusion once to twice a week. For red blood, it lasts, it varies from person to person because it's about blood volume. So how big you are, how much you use, but about 2 weeks.
Thank you for that. This question comes from a family who's getting ready to meet with the transplant team, and they said, thank you for the transplant slides. Their question is, can you explain the difference between the terms peripheral stem cells versus bone marrow?
Yes. This is not, I'm going to start by saying bone marrow transplant is not my specialty. It's a whole other area of expertise, but the stem cells can be floating in your blood as well, not just in your bone marrow. And during a bone marrow transplant, when you have healthy bone marrow, the donor does not need this is something that medicine has advanced over the years, but the stem cells are, you're given a medication to boost the stem cell production. So there's more in your blood. So they don't have to take the marrow from the donor. It's circulating in the peripheral blood. So they give you a medicine to boost it. So there's lots and lots of stem cells, and they take it from the peripheral blood versus harvesting, how they used to do it, where they would have to take it from the marrow itself.
Well, great. That was all of our questions for today. And there was a question, will the slides be available later? And yes, we can do that. Thank you for asking that. So thank you so much, Jen, for sharing your time and your expertise with all of us today. And thank you to everybody that submitted the questions as well. This webinar will be available on the platform that it's currently being streamed to within the next hour. And then it'll also be available on our website within just a few business days. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 40 years. This concludes our webinar. Thank you so much, Jen.
Thank you.
Have a good day.
You too. Thank you, everyone.